that lead to maternal cardiac arrest? What are the key interventions in maternal cardiac arrest? What about the importance of high quality chest compression, manual uterine displacement? What about the importance of maintaining airway and breathing in mothers and the perimortem cesarean section? Regarding the incidence, we know when a mother or pregnant women heart stop, we have to save two lives, the mother and the fetus. And recent data shows that cardiac arrest in US occurs in 1 in 12,000 admissions for delivery. And every day globally 8-10 maternal deaths are occurring. And maternal mortality is unacceptably high in India with 120 maternal deaths per day. Some statistics, we know the maternal mortality ratio in India has reduced from 130. The number in bracket indicates the maternal mortality ratio in Kerala. Per 1 lakh live birth in 14 to 16, it has reduced to 122. The number in bracket 42 indicates the number in Kerala in 15 to 17. And it has still reduced to 43 in Kerala per 1,000 live birth. And in 1920, maternal mortality ratio in Kerala is 28 per 1 lakh live birth. And total death in 2020-21, it is not maternal mortality ratio, it is the total death is 105, out of which 9 is COVID. So we know the target of Kerala by 2020 is to reduce the maternal mortality ratio to 30, and by 2030 we have to reduce the MMR by 20. There's some difference between maternal mortality ratio and rate. Rate is number of maternal death in a population divided by the number of women of reproductive age. Maternal mortality ratio is a small representation of maternal critical events. Critical events means life-threatening situations. We can say maternal near miss. Near miss means what? When we are taking the statistics of maternal mortality ratio, you have to think of maternal near miss or some severe critically ill situations. Maternal near miss is women who nearly died, but they survived a complication that occurred during pregnancy, during the childbirth, or within 42 days of termination of pregnancy. In 2021, from April to November, 162 maternal deaths occurred in Kerala. And Malappuram recorded highest number of maternal deaths. 32 women died in Malappuram. Okay, I have searched for some of the articles regarding maternal near miss, and I got an interesting publication from Thrissur Medical College. What are the factors associated with maternal near miss? They have studied over a period of 15 months. It was a cross-sectional study design, and there are some findings are there. During that study period, maternal near miss incidence ratio during that period of 15 months was 9.27 per 1,000 live birth. And the cause they found was delayed access to care. And there were previous reports of near miss rates from India that ranged from 3.98 to 17.38 per 1,000 live birth. Another interesting factor is rate of survival to hospital discharge following maternal cardiac arrest. Some journals report it as 58.9. And a journal on epidemiology of cardiac arrest during hospitalization for delivery, that study was conducted in Canada. What they did was, they have done a retrospective study over a period of 13 years. And they showed that women serve a total of 17 71.3% of women survive to hospital discharge. It's a very good number. So we should take initiative in timely resuscitation of this cardiac arrest or near miss. Okay. Now we shall go to what are the different causes of maternal cardiac arrest. We know hemorrhage is the most important cause, counts for 38%. Hemorrhage can lead to hypovolemic shock, and we are transfusing the blood that can lead to hypocalcemia, hyperkalemia. Over resuscitation can lead to pulmonary edema, disseminated intravascular coagulation. All these can lead to maternal cardiac arrest. Then cardiovascular diseases, myocardial infarction, aortic dissection, cardiomyopathy of pregnancy, valvular heart disease, myocarditis, even myocarditis following COVID that can cause maternal cardiac arrest. Amniotic fluid embolism, sepsis, aspiration pneumonia, preeclampsia and eclampsia that has a very good role in producing maternal cardiac arrest. Then COVID pneumonia. Some of the iatrogenic causes of maternal cardiac arrest are hypermagnesemia from magnesium sulfate administration, drug error or illicit drug administration, over administration of oxytocin above that is recommended by WHO, insulin administration, and some anesthetic complications. What are the different anesthetic complications that can lead to cardiac arrest? High neuraxial block, hypotension, loss of airway, aspiration, respiratory depression. Nowadays, there's a tendency for giving bilateral tap block. We are injecting nearly 15 ml of bupivacaine 0.25% bilaterally. That can produce, of course, local anesthetic systemic toxicity. So according A, B, C, D order, we can say A, anesthetic complications, already mentioned, bleeding, disseminated intravascular coagulation, uterine atony, placenta, abruptia placenta, and placenta previa. Cardiac causes already mentioned, drugs, embolism, fever, some general non-obstetric causes, 5X and 5Ts, hypertension, preeclampsia, and eclampsia. Now, to prevent this arrest, in all critically ill patients, an obstetric early warning score chart, color-coded score chart, should be used routinely. That allows us early recognition of the women who is becoming critically ill. I'll show the sample. It was developed by Carly et al. And there are 6 parameters they are monitoring. It's color-coded. You can see at the top and bottom, there are red color-coded colors. For each parameter, there will be numbers they are given. For systolic blood pressure, if the BP is below 80, they are giving a score of 3. If it is above 160, it's also a score of 3. Like that, for respiratory rate, less than 10 is 3, more than 30 is 3. Now, except for Glasgow Coma Scale, that is consciousness. If the Glasgow Coma Scale is more than 50, they are giving a score of 0. If it is less than 15, score is 3. So if the total score for all these 6 parameters are more than or equal to 6, we should trigger a call for support from the intensive care unit. And vitals should be monitored, and these patients should be monitored for further deterioration, and correction should be done. So how can we prevent cardiac arrest in unstable pregnant patients? Prevention is better. So patients should be placed in full left lateral position to relieve aortocaval compression. You should administer 100% oxygen by face mask to treat and also to prevent hypoxemia. Intravenous access should be established above the diaphragm. That means even if you are placing a cannula, it should be in the upper limb. Precipitating factors should be investigated and treated. Every hospital should have a pre-event planning preparation for cardiac arrest. You should educate the staff. Education to staff is educate all staff members for preparation for cardiac arrest. Even AHA 2020 recommend education as an important measure for prevention as well as for better outcome for cardiac arrest patients. So educate the staff about the management of cardiac arrest in pregnancy. You should prepare for perimortem cesarean delivery, cord calls, availability of equipments for cesarean delivery, resuscitation of neonate, all should be made. Then preparation for management of obstetric complications. You should have available drugs and equipments. Also, you should take decision involving the resuscitation status of the neonate. You should consider the viability of the baby. Now coming to the cardiac arrest topic. So far we are discussing about the causes, the chart, early warning chart, and also the how to plan for critically ill patients. Now we will go to the mother who is unresponsive with no breathing or no normal breathing, and the mother's uterus is at or above the uterus. What we will do? We should activate the emergency response system. So in maternal cardiac arrest, there's an arrest team. One bundled emergency cord call can activate all the members of the team. All the members in the team. That's called maternal code blue or code blue maternal. That serve as a universal call to action. It can save the time, unnecessarily calling anesthetists, gynecologists, neonatologists, etc. And it can help to prevent the confusion whether I have forgot to call the neonatologist, like that. And it can reduce the risk of team members not being notified. They can, the team members can bring the necessary specialized equipment also. This is the advantage. Then, which are the team members of maternal cardiac arrest? Adult cardiac arrest team, obstetric and cardiac anesthetist. This is a 2020 guideline. Obstetrician with scalpel, number 10 scalpel, ECMO team if available, and neonatology team. And also, if facility for echo is there, you should prepare for that echo. Who is a leader in the arrest team? Leadership depends upon where the arrest occurs. If the arrest occurs in the labor room, of course, the obstetrician may be the leader. If it is in the critical care unit, the intensivist should be the leader. That may be specific to the institutional practice. Now coming to the chain of survival. Chain of survival, these are different steps for better outcome of the patient. We know we have already discussed in so many CMEs about chain of survival, immediate recognition of cardiac arrest, and activation of emergency response system. That is one link in the chain. Early CPR with emphasis on chest compression, rapid defibrillation, advanced life support. There's some confusion. As far as possible, we can do perimortem cesarean delivery in the site of arrest. Then integrated post-cardiac arrest care and recovery has been added in a sixth link in the chain of survival. We have activated the maternal cardiac arrest team. Now you have to consider the etiology of arrest. Now the ALS algorithm goes into two divisions: perform maternal interventions and perform obstetric interventions. So when we are just a slide to show the call maternal cardiac arrest team, obstetrician with scalpel, already we have discussed, and consider transesophageal or transthoracic echocardiogram. Then chest compressions and manual uterine displacement, all this we are discussing in the coming slides. Intravenous or intraosseous access above the diaphragm. Intraosseous, they are recommending in the humerus. Now, what's the importance of high quality CPR in pregnancy? Why they are more prone for development of hypoxemia? One is, we know there is reduced functional residual capacity. FRC is reduced by 10 to 25%. 25%. Increased metabolic demands. Metabolic demands increased by 22% to 33%. Oxygen requirement, not demand, oxygen requirement consumption increased by 22 to 33%. Here the oxygen saturation curve is shifted to the right, and higher PO2 is required for adequate maternal oxygenation. There is chance for aspiration risk. All these predisposes the pregnant mothers for rapid development of hypoxemia. In all BLS algorithm, we are saying CAP. Here, Manual uterine displacement is also added. So you can say CABU. And to accomplish all these tasks, minimum 4 BLS responders should be there. The first responder should initiate the usual resuscitation measures, chest compression. Before that, they have to place the backboard. So there should be one person for placing the backboard, chest compression, airway management and breathing. Another person should be there for giving left uterine displacement, third person, defibrillation, fourth person. So a minimum of 4 BLS responders should be present. Now, where to place the patient? Patient should be placed in which position? Should be the supine position on a hard surface. The forces when we are giving chest compression in supine position may result in mattress displacement during chest compression. That's the importance of placing backboard. When we are placing backboard, we can give a very high quality of chest compression. And another thing you have to remember is placing the backboard should not produce any delay in initiation of CPR, and it should not produce interruptions in CPR, and it should not produce line or tube displacement. If the patient is on air-filled mattresses, that should be deflated before chest compressions. Position. Previous guidelines recommended placing the hands slightly higher on the sternum in pregnant women, but there is no scientific data to support this recommendation. And hands are placed in the lower sternum or in the center of the chest itself. And heel of the palm of one hand in the center of the chest and other hand on the top with fingers crossed. And elbow should be straight and force should come from the upper half of the body or from the shoulders. Compression rate, we all know 100 to 120 compressions per minute. Depth of compression 5 to 6 centimeter deep. For producing high quality chest compression, allow complete chest recoil, and rescuers should avoid leaning on the chest between the compressions. Minimize interruptions in chest compression. When shall we interrupt the chest compressions? We should continue chest compression until return of spontaneous circulation or termination of resuscitative effort. Then you can interrupt compressions while giving shock, then during rhythm interpretation. Then another thing is the pre-shock and post-shock pauses before giving shock and after giving shock. That pauses should be as short as possible. Why I'm saying you should minimize compressions? There is one term, chest compression fraction. Here you can say, see, after 30 compressions, we are giving 2 ventilations. That means 2 seconds. 2 seconds means 4 compressions. And after 60 compressions, we are giving another 2 seconds, 4 compressions. So 4 plus 4 plus at 90, another 4. So out of this 120, it should be nearly 105. That means for unprotected airway, the chest compression fraction should be more than 60%. What are the factors that can affect chest compression in pregnancy? This is an important data. Manual uterine displacement should be performed in all women who are in cardiac arrest when the uterus is palpated above umbilicus or at umbilicus. Here, when we are giving chest compression in adult victim, even we are giving a high quality chest compression, that can provide only 25 to 33% of the normal blood flow. In pregnancy, even if we are performing a well-conducted CPR, there will be practically no cardiac output if we have not performed manual uterine displacement. Previously, left lateral tilt was recommended, but it is not advocated nowadays because historically it was recorded. And recently it is found that more than 30-degree tilt, the mannequin slit of the inclined plane. Other disadvantages are chest compression forces was reduced when we apply tilt, and more than 30-degree tilt can produce IVC compression. Moreover, the heart will be shown to be shifted laterally. And if an echo is there, you can do a transesophageal echo and locate the position of the heart for giving effective chest compression. So easier access, this manual uterine displacement can produce an easier access for patient is in supine position with just a lateral displacement. So when the patient is in supine, you can get a good access for both airway as well as for defibrillation. Patient can remain supine and they can receive the usual resuscitative measures, high quality chest compression without any hindrance. How to perform manual uterine displacement? You should not push down. That can increase the IVC compression and venous return will be reduced. It can be from the left side of the patient. What they're doing is uterus is cupped and lifted up and leftward off the maternal vessels from the left side of the patient. Or it can be from the right side of the patient, can be pushed up and leftward off the maternal vessels. You can see how the person is performing the manual uterine displacement from the right side of the patient. Now coming to so we have discussed the chest compression, manual uterine displacement. Now coming to the airway and breathing. Early ventilation, already we have mentioned hypoxia is considered as an important cause of cardiac arrest. Oxygen reserves are lower, FRC is 25% lower, metabolic demands 33% increased. You give rescue breath over a period of 1 second. Gives how much tidal volume? Sufficient tidal volume to produce a visible chest rise. If you have a self-inflating bag with a non-rebreathing valve, give mask ventilation with 100% oxygen and flow should be at least 15 liters per minute. Two-hand bag ventilation is preferred than one hand. Avoid hyperventilation. We know in pregnancy, respiratory rate is increased and they are in slight metabolic alkalosis. So you should not hyperventilate the patients. Airway management should be done by an experienced laryngoscopist. Forceful laryngoscopy should not be done. It can lead to bleeding and airway edema. No more than 2 attempts at scopy or video laryngoscopy. Use small endotracheal tubes, 5.5 or 6. In between laryngoscopic attempts, you do for face mask ventilation. What's the role of cricoid pressure? If your scopy is interfering by pressing the cricoid at the level of cricoid cartilage, you relieve the pressure. Or if your view is getting less clarity, you just relieve the cricoid pressure. No advantage. Now, if oxygenation and ventilation are not successful with a supraglottic airway device or with your endotracheal tube or mask ventilation is impossible, then declare a cannot intubate and cannot oxygenate situation. Should call for help and emergency invasive airway access, thread of neck access should be established. What's the role of continuous capnography? Qualitative measurement of your qualitative assessment of your chest compression and also correct placement of endotracheal tube. But if the patient is suffered from amniotic fluid embolism or pulmonary embolism, you cannot assess the correct placement of endotracheal tube. Then you can assess the quality of chest compression and return of spontaneous circulation. If the EtCO2 value, if the value is sustained more than 10 millimeters of mercury, return of spontaneous circulation is more likely. Probability of resuscitation will be there. Then, if there is an abrupt increase in EtCO2 by 10 millimeters of mercury, that is consistent with return of spontaneous circulation. Now coming to the electrical therapy or defibrillation. Shall we remove the fetal monitors? No. Unlikely to cause electrical arc. So, most of the time, shall we use a biphasic defibrillator or AED? Staff have no rhythm recognition. If the staff have no rhythm recognition skill, or defibrillators are used infrequently, especially in obstetric unit, use of AED may be considered, automatic external defibrillator. Can I use defibrillator on a pregnant woman? Yes, AED can and should be used on pregnant women who is in cardiac arrest. It is a rhythm of cardiac arrest. Can be ventricular fibrillation, pulseless ventricular tachycardia, asystole, or pulseless electrical activity. First two are shockable rhythm and the other, the iterate, are non-shockable rhythm. Class 2A is the recommendation. It is reasonable. Androlateral defibrillator pad placement is recommended. Lateral pad should be placed under the breast tissue, or you can use adhesive pads. Same pad position on both male and female. About the energy level, say biphasic energy. If you are using biphasic energy, 120 to 200 joules with subsequent escalation. That's also class 1 recommendation, strongly recommended. But after defibrillation, we should go for chest compression. IV line above the diaphragm, already mentioned. About arrhythmia management. For refractory ventricular fibrillation and tachycardia, amiodarone injection 300 milligram bolus dose followed by 150 milligram. You should not alter the dose to accommodate the physiological changes in pregnancy. Also, no medication should be withheld because of the concern regarding fetal teratogenicity. This is a class 2B recommendation. Other drugs, ephedrine, 1 milligram IV or intraosseous every 3 to 5 minutes. Atropine not recommended. Atropine may be used only for bradycardia after arrest or for bradycardia. What about perimortem cesarean delivery? It's a class 2A recommendation. Perimortem cesarean delivery is in 2021. What they recommend is perimortem cesarean delivery should be strongly considered for every mother in whom return of spontaneous circulation has not been achieved in 5 minutes of resuscitative effort. Previously, it was saying as 4 minutes. Now they say change to 5 minutes of resuscitative efforts. Shall we transport the pregnant women during chest compression? No. Perimortem cesarean delivery should occur at the site of arrest itself. Transport is required only when required. Example, for out of hospital cardiac arrest, or when cardiac arrest is occurring in a hospital not performing cesarean section. For doing perimortem cesarean delivery, team should not wait for surgical equipment. Only scalpel is required. Number 10, scalpel. Team should not spend time on lengthy antiseptic procedures, poor antiseptic solutions. Maintain continuous uterine displacement. Avoid injury to the rescuer performing manual uterine displacement during perimortem cesarean delivery. There is chance of injury to rescuer. What is the importance? Advantages? You can separately resuscitate the potentially viable fetus, and because of relief of aortocaval compression, maternal resuscitation outcome will also be better. You can do either vertical fennel steel incision or vertical incision. That depends upon the experience of the obstetrician. And during resuscitation, fetal assessment should not be performed. That's class 1 recommendation. Fetal monitor should be removed or detached as soon as possible to facilitate the perimortem cesarean delivery. But during defibrillation, there is no need to remove the fetal monitors. What about in COVID-19 patients? Before aerosol generating procedures, apply PPE. In pregnancy, difficult airway is common, so you call for experienced anesthesiologists. And for all ventilations, use HEPA filter. A central registry of cases of maternal near miss and cardiac arrest with documentation of the outcome and the documentation of the process during resuscitation should be established. That's class 1 recommendation. And we should have frequent training courses in maternal resuscitation. All cases of maternal cardiac arrest and maternal near miss should be reviewed. Auditing should be there by maternal cardiac arrest committee of the hospital. And by that only we can correct our deficiencies. That's also a class 1 recommendation. This is a cognitive aid checklist. Sometimes we may forget some of the steps. So it's very good. It's a very good aid checklist. Call for maternal code blue. Whether you have done, you can tick it. You have to record the time also, indicate the time. Then backboard placement, time, whether done or not. Immediate basic life support, AED, maternal airway equipment, like that confocal and start of CPR. During circulation and chest compression, whether manual uterine displacement was done or not. Hands in the mid-sternum, 100 compressions, like that goes. Then airway, minimize interruptions in chest compression, chin lift, jaw thrust, like that. Whether 100% oxygen was given, whether it is more than 50 liters, and breathing, defibrillation. So special attention should be paid to manual uterine displacement, difficult airway, and appropriate use of perimortem cesarean delivery. Defibrillation and medication should not be withheld in the setting of pregnancy. And healthcare community must be proactively prepared to respond to maternal cardiac arrest. Okay. So every hospital or every institution should have a maternal cardiac arrest committee, and emergency response plan should be implemented that is specific to each institution. And periodic multidisciplinary drill may help the institution to optimize the safety system. Just a recall of what we have discussed. Thank you.